Welcome to RSNA 20 Image Interpretation Panel. We're coming not from the Airy Crown Theatre, but we're coming from your laptop this year because of modifications for COVID once again. But we do have 8 fantastic cases for you this week, 2 every day. And today's 2 cases are going to be abdominal and pediatrics. I'm Christine Glastonbury. I'm a neuroradiologist, but I'm delighted to introduce to you 8 panelists, experts in radiology. So the theme this year is a little different to usual. And what I wanted to emphasize in today's presentation and all the presentations this week, that's the actual process of working through difficult cases is really the magic that makes really good radiologists. And I've always found that the most fun being in the reading room is listening to the genius of people working through how they get through difficult cases. So this year we did the panel a little differently to previously. In the last week of September, I sent out some cases, and in some cases, like with the first case you're going to see today, I sent out a lot of images because I think if you present someone with just specific images in a study, it really biases them as to what you want them to know. They then got back to me, each of the panelists, back and forth over the 2 weeks, and here we are recording in the second week of October so that you can hear this at RSNA. So it's a real back and forth, interactive, and the point here is to be just as you would be in the reading room, although they're not really supposed to consult with anyone. I'm sad to say that Fergus Coakley, our first panelist today, did not succumb to bribery, although our email discourses were extremely entertaining. So let's go with the abdominal case. So I'd like to introduce to you Fergus Coakley. He's the department chair and a professor of diagnostic radiology at the Oregon Health Sciences University, where he's been since 2012. Dr. Coakley has been an active clinician, teacher, and researcher. His main research interests are MR-guided high-intensity focused ultrasound for cancer therapy and tumor ablation, as well as being widely published and a frequent lecturer and sought-after expert in CT radiation dose and MRI of prostate cancer. Dr. Coakley was born in Cork in Southern Ireland. And he went to medical school here as well at the medical school at University College in Cork before going to Dublin for medical residency, then Leicester for radiology residency. He left the UK for the United States in 1996 to be a fellow in body imaging at Memorial Sloan Kettering in New York before joining UCSF the following year, where he eventually became the chief of abdominal imaging and the vice chair for clinical services. In 2012, he moved to Portland, Oregon to become the chair of radiology. And you can see that's kind of hidden under the clouds here, nice and wet and green in Portland, just like Ireland. When I asked panelists to send me their photos, Dr. Coakley sent me some really interesting generational photos here. On the left, you see his parents with his grandfather. And his father, a pathologist, was just receiving his postdoctoral medical degree. The photo in the middle is a very, very proud mother, while her son, Fergus, is getting his doctorate in 1988. Now, Fergus was like his father in that he too received a postdoctoral medical degree. He's at the National University of Ireland, and interestingly, it was in pulmonary CT, not in abdominal CT. The final photo here is Fergus and with his wife, Sarah, and his kids at Declan's high school graduation this past May. I also asked each of the panelists why they were interested in radiology. And Fergus, once again, has demonstrated his interest in the intellectual challenge of problem solving. So now we're going to go right to it. And welcome to Dr. Fergus Coakley.
Thank you, Christine. And let me begin by saying thank you for this invitation to be on the image interpretation panel. And fortunately, I'm spared the public embarrassment of humiliating myself in the Airy Crown Theatre as I stumble through this case. So this is the history that you gave me. As I said to you, my initial reaction is that Christine has mistaken me for a rheumatologist. We have a 67-year-old man carries a diagnosis of granulomatosis with polyangiitis, diagnosed 3 years previously. One of the things I had to do was Google that term because I had learned it as Wegener's granulomatosis, so not a term I'd been familiar with because I've gotten so old and out of touch, I guess. The other thing I note here in the history that I thought I just wondered if it was relevant, I don't think it turned out to be relevant, was that he had medication changes. He'd been on azathioprine, and that dose had been increased shortly before his presentation. I wondered if that was pertinent. And his rituximab had been stopped also in the summer before his presentation. I'd wondered if some of that was connected. Again, I don't think it was when we finally see the diagnosis, but those things sort of caught my eye. And then we move to the imaging. He has an ultrasound and a CT that we're going to see next. On the ultrasound, probably on that longitudinal image, we see there's a mix of echogenic and hypoechoic, for want of a better term, stuff around the kidney. There is, of course, no hydronephrosis, which had been the reason to do the ultrasound. So really non-specific appearance, but this extra tissue, mainly visible around the right kidney, but a little bit on the left kidney as well, but certainly more right-sided. And then on the CT, much as we had seen on the ultrasound, we see extensive infiltrative abnormality around both kidneys, and then extending downwards in the retroperitoneum, tracking along the ureters perhaps, a little bit more on the left side there, and then down in the pelvis, so clearly pretty bilateral. And we see this big, thick rind of tissue around the rectum and the bladder. So interesting appearance. So my first thought process was really to dismiss this just being straight up hemorrhage, which of course could be a possibility, but usually we see more focal hematoma, maybe a fluid level or something, and it didn't seem like just straight up bleeding would have been the kind of case that would get into the image interpretation panel, but I'm just mentioning that for completeness. And then I went to my mnemonic SALTY, and this is one I use for weird infiltrative pathology. S is for sarcoid, A for amyloid, L for lymphoma, maybe including myeloma and metastatic disease as well. T is for TB, and also maybe thinking about other odd, opportunistic or atypical infections. And then the I is for IgG4 disease. And that's a good little mnemonic to keep in your mind. And I need to credit Ellie Korngold, who's our Chief of Body Imaging at OHSU, previously trained at MGH, who gave me that little differential. When you're struggling with a differential diagnosis, think about making it SALTY and adding these thought processes. So then I did some Googling around all of these differentials. They're in really no particular order here. Certainly on number 2, IgG4 disease, somewhat more mass-like typically, but could certainly overlap with the appearance that we're seeing in this case. Amyloid, interestingly, I found a case report where amyloid was pathologically initially misinterpreted as Wegener's granulomatosis, so I even wondered if perhaps the original diagnosis was mistaken. Certainly lymphoma is a recognized entity that could arise, of course, either independently or as a complication of Wegener's granulomatosis. And then finally, sarcoid, something to think about, though typically we might expect a little bit more discrete adenopathy as against a purely infiltrative process here. So things that I thought were particularly likely here, I was thinking lymphoma and amyloid, and in no particular order, perhaps IgG4 disease as well as my leading considerations. And then I asked Christine for some more information. I thought it'd be good to look at the original chest CT and just really check the initial diagnosis. And the bottom line here is there was this mass in the chest that had been biopsied. And Christine also told me that there was a kidney biopsy about the same time. That was apparently conclusively proof of the diagnosis of Wegener's granulomatosis. So I dismissed the idea of a misdiagnosis. So we're sticking with that as being a true diagnosis. I asked for serum IgG4 level. This was a swing and a miss here because it turned out it was a normal IgG4. Would have been a nice idea, but doesn't seem likely based on that normal IgG4 level. I thought about testing the blood and urine for light chains, again, just keeping myeloma as sort of companion thought along with lymphoma. There was basically only minimal abnormality on these light chain results. So again, nice idea, but probably one we will dismiss. And then finally, I asked to see if there'd been a biopsy. And really, we'd spent a lot of time guessing what tumors might be. But in reality and in practice, this is probably going to be the key test and the inevitable procedure that needs to be done independent of what we might think this process is. So that was my next recommendation. And I got this information back. There'd been an FNA of the right perinephric abnormality with a lot of hand waving here, but essentially this is a non-diagnostic biopsy. And I'm not a huge fan of FNA biopsies for the most part. And I guess this depends to some extent on whatever institution you work at and the expertise of your pathology department and their ability to provide high-level cytological interpretation. But I must admit, I do prefer core biopsies for the most part. I think they're more dependable. So my final suggestion was we should do probably a CT-guided biopsy, probably a core biopsy. And again, at this point, my two leading thoughts remained lymphoma and possibly amyloid.
So after that back and forth, the CT-guided biopsy came back plasmablastic lymphoma. Excellent diagnosis, Professor Coakley. And that was the article that you had sent, the article about malignant lymphoma in patients who have GPA was your reference, which I was holding as the one reference I would share with the audience as a useful article. But in fact, it doesn't even mention plasmablastic lymphoma in this paper because this is a very uncommon aggressive subtype of diffuse large B-cell lymphoma that's usually a head and neck tumor seen in patients who are HIV positive. But if you're looking to read more about perinephric masses, there's a very good article written by Dr. Coakley himself where he describes the imaging features of different types of perinephric masses. So, well done, Professor Coakley. A thank you to Dr. Wang and Dr. Zagoria, who shared this case with me and were hoping to stump Dr. Coakley. They'll be very disappointed to see that he did excellently once again. But thank you very, very much, Fergus. It was a terrific case, and well done.
Thank you, Christine. And again, thank you for this opportunity to be part of the image interpretation panel.
Okay, well, now we're going to move to our pediatric case for the afternoon, and I'd like to introduce to you Dr. Harriet Paul-Till. Dr. Paul-Till is a professor of radiology at Harvard and the physician co-lead of ultrasound at Boston Children's Hospital. She has clinical and research expertise, particularly in the area of ultrasound in pediatric imaging, and unfortunately, the case you're going to see today does not have any ultrasound images. Dr. Paul-Till has many roles in the Society of Pediatric Radiology and is currently the chair of the Publications Committee. Professor Paul-Till was born in Toronto but grew up in Montreal, Canada, and attended medical school at McGill University in Montreal, where she also did her radiology residency training before going to Boston Children's Hospital for a pediatric radiology fellowship in 1986. She went back to Canada before returning first to the University of Cincinnati in 1990 as an assistant professor, and then to Boston Children's Hospital of Harvard in 1992. So I asked Dr. Paul-Till whether she had any detours along the way in her career, and she proves to be another extraordinary and very well-rounded academic. Dr. Paul-Till was a serious medical student prior to medical school, studying both the piano and oboe, and completed a musical degree in her third year of medical school. Before she completed her radiology residency, she also spent a year as a pathology resident and a year as an internal medicine resident in Canada also. But her best detour, or perhaps better said as the best destination, is her family, her husband Eric and her son Emile. As a trainee, Dr. Paul-Till was inspired by the radiologists around her at the Montreal Children's Hospital, particularly Michelle Azouz, who inspired her to become a pediatric radiologist, and also Sigrid Jequier, who fostered her love of ultrasound. So welcome to the RSNA 2020 Imaging Interpretation Panel, Dr. Paul-Till.
Thank you so much, Christine, for that lovely introduction. I want to thank you very much for inviting me to discuss the very interesting case that you sent to me, and I learned a lot from it, and I'm really looking forward to sharing that with you, the audience, this afternoon. May I have the first slide? So this is the history that I was sent of a 12-year-old girl who presented with severe anemia, right ankle pain that was thought to be related to a car accident she had had sometime in the past. And she also had an elevated inflammatory markers, and ultimately a CT of the chest, abdomen, and pelvis was ordered to rule out vasculitis or other inflammation of the chest or abdomen. And before we move on to look at some of those images, some additional relevant history is that she is Hispanic, and she presented with a lot of systemic symptoms of fatigue, lightheadedness, pallor, headache, depressed mood, and she had a very low hemoglobin and a microcytic anemia. She had a history of obesity and had subsequently lost weight intentionally. She denied any fever or pain, nausea, night sweats, or respiratory symptoms. She was eventually treated with some red blood cells and iron, but her anemia persisted, and she had thrombocytosis, and she had a very extensive workup with inflammatory markers. And ultimately, she was referred to the GI service for evaluation for possible malabsorption due to inflammatory bowel disease. And ultimately, she had some endoscopy, and the upper GI tract was normal. And now I think we'll move on to look at her CT of the chest, abdomen, and pelvis. So here are some images from the chest portion of her study. On top, we have the soft tissue windows. And I think the pertinent negatives here are that we don't see any lymphadenopathy. The heart, the pericardium all look normal. The esophagus is collapsed around a tube, but otherwise seems to be normal. And in the lower panel, we can see that her lungs look normal as well. And the pleura are clear, and really this looks entirely negative. Next, please. So now let's look at her abdomen and pelvis. So as we move down the abdomen, in the top row, in the middle panel, we see a few mesenteric lymph nodes, mildly enlarged, but the most obvious and striking abnormality here is the very large, lobulated, very heterogeneous pelvic mass that's displacing the iliac vessels laterally. And posteriorly, you'll see that part of the rectosigmoid is displaced to the right. It's a little difficult to see the other pelvic organs on the final image on the right-hand side. That may be the uterus back there. Perhaps the ovaries are seen anteriorly on either side, but they're really not very well shown. So let's go on to the next set of images. Okay, so on these first two coronal images, we can see in the left-handed image that there's an enhancing nodule in the omentum there below the liver. And once again, we can appreciate some enlarged enhancing lymph nodes. We can see that the mass in the pelvis has some calcification within it, and it appears to have a distinct plane between it, the mass and the bladder. And the liver looks fine, and what we can see of the other visceral organs also looks normal. The kidneys look normal, and I saw some additional images that showed that the spleen and the pancreas were also normal in appearance. So at this point in time, those were the images I had received. I had a preliminary differential diagnosis trying to put together the history along with the findings. So there were several possibilities here. The very heterogeneous mass looked tumor-like, which led to my top diagnosis of an inflammatory myofibroblastic tumor. And in addition, I thought that it could explain a lot of this patient's clinical findings, because it can definitely be associated with anemia, with elevated inflammatory markers and so forth. So that was my first diagnosis. But then, of course, given that she had such prominent inflammatory changes, I had to consider as well an abscess from inflammatory bowel disease, as we were shown was certainly a consideration when she presented. But with the caveat that the bowel really looked normal, apart from that displacement of the rectosigmoid, I didn't see anything on those images that would really point to inflammatory bowel disease. There was no neural thickening, really didn't see inflammatory changes in the surrounding soft tissues either. The other option was pelvic inflammatory disease. Again, this would be an unusual diagnosis in a 12-year-old girl, likely not sexually active, so that raises the question of whether there might be a history of sexual abuse, or a history of prior surgery that also can sometimes be complicated by the development of inflammatory disease and an abscess. And then, of course, other tumors that could have a similar appearance but would not generally present with the inflammatory markers. So that would be rhabdomyosarcoma and lymphoma, or a gastrointestinal stromal tumor, could all have this particular appearance. But again, clinically, they don't seem to be as high on my list of differential diagnoses because they don't explain all the clinical features. So I think we can now move on. So at this point, I did ask Christine for some additional information. So first of all, I wanted to know, did this patient have a small bowel follow-through or a colonoscopy? I did ask about the history of prior pelvic surgery or sexual abuse. And then I asked the last question, which I guess in retrospect was an unfair question, but I asked if the patient's symptoms resolved after the mass was removed, because again, that would favor inflammatory myoblastic tumor, because typically the symptoms will resolve completely. And then, of course, I wanted to know, did she have any additional imaging, specifically MRI? So I think before we move on, let's just discuss the findings. So she did not have a small bowel follow-through, and she did have some scattered aphthous ulcerations in the cecum. Now, the cecum, to me, on the basis of the CT, looked normal. It's kind of a non-specific finding, but again, it does go along with inflammation. And I think now we could move on to the MRI. So the MRI was very helpful for me because it clarified the relationship of the mass to the adjacent pelvic structures. So the pointer is showing you the right ovary there, which looks completely normal, and we can also see the left ovary. There is a little bit of free fluid. Again, we see that this is a very heterogeneous mass with some necrotic features. And also in the upper left-hand panel, we can appreciate that the uterus looks completely separate, and at least on this image looks very normal, and it looked normal on the other images as well. On these sagittal views, we can see that the mass is clearly separate from the bladder, which we had suspected on the CT as well. And it's clearly separate from the uterus, which is displaced posteriorly. And again, we can make out the ovaries, which look normal. And again, we can see that the mass abuts the rectosigmoid, especially on that final right-hand panel, but is not clearly arising from it. So I think at this point, oh good, we have some additional coronal images as well. It wasn't clear to me where this mass was actually arising from. It didn't seem to be involving the pelvic organs. And there was some displacement of the rectosigmoid. And I think on the left-hand panel here, we see some adjacent bowel loops, perhaps not clearly separated in the upper midline from those small bowel loops. So I was kind of left saying to myself, well, it's probably arising from bowel, because I believe she did have some aphthous ulcerations in her bowel. And I did ask for some additional lab work. But before we get to that, here are some more images from the MRI. After contrast enhancement, again, we can see that there are large areas that do not enhance, that look necrotic, cystic or necrotic, but the irregularity to me would favor necrosis. Again, we don't see any pelvic sidewall involvement. There may be some sort of satellite nodules, but we don't clearly see signs that would imply that this was a malignant tumor like a rhabdo or a lymphoma or anything like that. So I did ask about fecal calprotectin and occult blood. And I also wanted to know, did this patient recently emigrate from somewhere in the developing world? And the reason I asked that was that occasionally patients can have tuberculous involvement of the abdomen, either with or without involvement of the lungs. It is rare. It generally involves young women or older women of childbearing age and who have ingested infected dairy products that are not pasteurized. So tuberculous a tuberculous abscess was also a consideration. So I did get some response here. So fecal testing was negative for blood, and the calprotectin was sort of borderline, so it wasn't particularly helpful. She had not recently emigrated. However, she did travel frequently to visit relatives in Mexico and also Puerto Rico, Texas, Los Angeles, and visits from relatives came as from relatives also had occurred. So this was very helpful in terms of finally ordering my differential diagnosis. So number one would be infection. This is a Hispanic female with relatives in Mexico, frequent travel back and forth, could very easily have ingested some contaminated dairy product and would explain both the appearance of this very necrotic looking lesion, a necrotic mass, and would also explain all of the inflammatory changes that she had. Second on my list was an inflammatory myofibroblastic tumor, because it too has protein manifestations. It can look like anything, it can occur anywhere, but it does tend to occur in the abdomen arising from the omentum or the mesentery. These other two choices, GIST and inflammatory bowel disease, are lower down on my differential because although they explain some of the findings, in the case of the GIST, it certainly explains the appearance of a mass, and it can be associated with anemia. It doesn't explain all of the inflammatory changes. And finally, inflammatory bowel disease would explain some of the findings like the aphthous ulcerations and the fact that the mass does seem to displace bowel and can't be clearly separated from the bowel in all of the images. But again, most of the bowel, as far as I could tell, looked completely normal. So ultimately, I think the only way to really find out what this lesion is to resect it, to examine it pathologically, to do special stains for mycobacteria, and I will leave the discussion at that.
Well, thank you very much, Professor Paul-Thiel. So, in fact, this young girl did go to surgery, and a mass was resected from the omentum and found to be fixed to the appendix. And there were multiple abdominal lymph nodes, and it was shown to be granulomatous and grew Mycobacterium bovis. Well done. This was your number one diagnosis. So Mycobacterium bovis primarily affects cattle, but can be an important human pathogen causing extrapulmonary TB in children who have a negative chest X-ray. And it has been very well described in Hispanic children in California, with Mycobacterium bovis being isolated from unpasteurized soft cheese, the queso fresco, and in cheeses in Mexico and in cheeses from Mexico entering the US. And that was the best explanation of the origin for this infection in this young girl. It's very difficult to treat this because it's usually universally resistant to some of the typical medications. But she has done very well since resection, and treatment has started in this case. So congratulations, Dr. Paul-Thiel. Not a common thing I imagine you see in Boston.
Not too often.
And I'm sorry that there was no ultrasound. And we need to thank or condemn Dr. Caracas Rothi, who is at Benioff Children's Hospital, Oakland of UCSF, who shared this case with me. So I thank her for her help. But I would like to close the session with a very big thank you to our two outstanding professors to this afternoon, Professor Coakley and Professor Paul-Thiel. I thank you very much for your time and your energy and enthusiasm, and for your brilliance in sharing how you do with difficult cases. Thank you.
Thank you.
Please join us tomorrow. We'll do 2 more cases tomorrow, the MSK case and the nuclear medicine case at the same time tomorrow. And please enjoy the rest of your virtual RSNA 2020.